we're off. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I am your host. I'm a filmmaker that's been working with CCF for almost 10 years to create video content that helps spread awareness and education about NETs, neuroendocrine tumors. If you are a friend of the foundation and a friend regular to the show, you know the drill. Go ahead and let us know where you are signing on from in the world. Say hello to everybody in the comments. And also, you may notice if you're a regular that your host has a new background. I have changed offices in my complex, also known as my home. We rearranged things, and so now I'm in the bonus room above the garage, which gives me a lot of room, but the walls are a little naked, and you know it's new, but I'm excited about it. So if you were totally concerned about what was going on, and if you were in the right show, don't worry, you are, my friend. So before we get started, we just want to thank our sponsor, Tercera Therapeutics. Without them, this program wouldn't be possible. But we always like to give a disclaimer at the beginning of the program from the sponsor that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that's you all at home, haven't been created or suggested beforehand by the sponsors, and CCF does not endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So, of course, that last part is really the takeaway. We're going to give you some great information. We've got a great guest. You're gonna learn a lot today, I hope. But we don't know your specific case, so by all means, take the information that you get, send it in the right direction so it can get you on the next step. Talk to your home team about it and see if you can make the right path forward. So today our guest is my friend of the foundation, Dr. Aman Chauhan, who has been on previous iterations of the show before. We had a Facebook Live we did back in the early days of COVID, which is close to a year ago now, which is wild. And we've had him on other videos that we've done. We started off this season with a lot of great guests, and I'm very excited to have him. I would consider him one of the rising rock stars in the neuroendocrine tumor community. He's been with us a lot of times. Dr. Chauhan, how are you? Say hello to the folks and let us know what you do, where you do it, and how you serve the neuroendocrine tumor community.
Thank you, Rain. Thanks for having me here, and
Of
thank
course.
you, Carcinoid Cancer Foundation. This series has definitely skyrocketed. I see it growing in popularity, and I think that's one of those silver linings with the pandemic. It has really given us new platforms to spread the awareness for neuroendocrine cancers, and we often see patients joining from all over the globe. And hats off to Carcinoid Cancer Foundation for making that happen. And Rain, great to see you.
You too, buddy.
Earlier we were talking. I think one of my bucket lists to do this year is, Rain can do a flag. That's really difficult to do. So I was hoping that this year I can get, of course,
I wish I had a picture to show everybody, but I'll try to explain. It's a calisthenics. It's a body weight move called the human flag, and essentially, your body is parallel to the ground, hanging in midair, and you're holding on to either a flagpole or something so that you are completely parallel to the ground, just holding yourself up by your hands. My dad also used to be able to do it, but it's a neat little party trick.
it's
But
pretty awesome. It
don't
looks
try.
easy, but I can tell you it's probably going to take me several years to get to that
If you
level.
value your rotator cuffs and you're a beginner, don't try that at home. But I'll try to I'll try to show a picture sometime. But tell the world, tell the friends of the foundation where you work and what your role is there.
Great. So I'm one of a medical oncologist at University of Kentucky. We have a standalone cancer center called Markey Cancer Center. It's the only NCI designated cancer center in state of Kentucky. I got involved in neuroendocrine cancer quite early in my training. I came to United States to get trained in both internal medicine and pediatrics. And I kind of knew early on that I love the field of oncology, but I wasn't sure whether I'll go towards the pediatric cancers or the adult cancers. And I was doing my training at LSU New Orleans, and as some of you might know, we have a pretty strong neuroendocrine program in New Orleans called NOLA Nets. And at that time, my mentors there, Dr. Boltring, Dr. Boudreau, Dr. Ramirez, they really got me interested in neuroendocrine cancers. And so I started very early. I mean, I'm talking about residency. So I had that advantage of kind of getting looped in with experts really early in my career. And when the time came for me to do a specialized training, what we call fellowship, uh, dedicated for oncology and hematology, they directed me to come to Kentucky. And we had two of the global giants in neuroendocrine cancers. One's Dr. Ed Volin, who is now in Mount Sinai, but at that time he was in University of Kentucky, and the other Dr. Lowell Anthony, who is our division chief. This was the best place for me to get trained by two of two of the biggest names in the field. So I feel very lucky. Back in 2015, I landed here, got dedicated neuroendocrine cancer specific training for 3 years because of these two great mentors. And then I stayed back in 2018 in Markey Cancer Center to join our NET clinic. And now me and Dr. Lowell Anthony, we run our neuroendocrine cancer clinic. I'm the director of NET Theranostics program. As you all know, that this new field of theranostics, PRRT, is taking off big time. And it kind of really piqued my interest early in the career. And I'm involved in a lot of clinical trial development related to PRRT, and we can talk about it a little later. But that's the program I direct here at Markey Cancer Center. Another area of my interest, both clinical and research, is high-grade neuroendocrine carcinomas, which unfortunately we haven't seen a lot of improvement and development in this kind of area because they are rare and they are also very aggressive. So that's another area of my interest, and we are hoping to kind of make some leap forward in terms of outcomes in these
Mhm.
rare and aggressive cancers as well, in addition to, of course, are low grade or well differentiated neuroendocrine tumors.
Awesome. Thank you so much. Well, everybody at home, the numbers are looking great. We got a great group here today. Welcome. If you joined us a little bit late, this is Luncheon with the Experts, and our guest today is Dr. Aman Chauhan. If you know someone who is, a patient that's going through this disease, a caregiver, a support group leader, anybody that would benefit from this is going to be an amazing episode. Dr. Chauhan is the truth. A lot of great information. As he just told you, he's studied from the best of the best in this community, and he told you what he kind of specializes in. So go ahead and send your questions in. But if you know anyone else who would benefit from this, you can tag them in the comments. You can share this video. Let's get as many people as we can as possible here in the room, because this is a unique interactive experience where they can ask questions. The video is going to live here. You or they can always refer back to the video, but if they might have a question that Dr. Chauhan can answer, let's get them here now. So I see that we've got people from the UK. I missed that comment. Doina from the Andrea from the UK, Andrea from Trinidad and Tobago. Lots of great people here. So let's go ahead and start filling up the room, getting more people here. Send your questions in. We may not get to all your questions, just know that, because we always get a lot of them, which is exciting. We're excited about that. That's what we want to do. We want to help answer some of them. So if we don't get to your question, I urge you to follow up the Carcinoid Cancer Foundation. You can message them here on Facebook, or you can visit carcinoid.org and email them or reach out to them there, and they will get you the information that you need. One tip that I've had, you all have been doing such a good job of this. It's very, very helpful. So I'm going to continue to ask for your help on this. If you see a question in the comments in the sidebar that you also have, or you're like, hey, I'd love the answer to that too, just like that question or love it. There's a bunch of different emojis you can choose, but they all serve the same purpose for me. It lets me know that other people that have that question, that it's in demand. It kind of upvotes it, because we get so many questions, we inevitably can't get to them all. We can't get to very case specific questions either. So if you do that, it lets me know that there's a lot of people asking this question. I'll make sure to do my best to get it across. Speaking of the case specific, I know we touched on that. We can't, Dr. Chauhan doesn't know your specific case. So try to ask your questions in a general way. If it's too case specific, we'll just be, try to give you general advice to help you out. And hopefully that does, but stick around for the conversation. We may need some more information from you. You may be able to clarify your question. So don't just ask it and go, be a part of the community. That's one of the things I love so much about the show, is the interactiveness and you all having comments and talking to each other. such a good thing. Before we get started, my last question is, have you downloaded CCF's free Net Cancer Health Storylines app? This app is awesome. It makes it very easy to record your symptoms, medications, nutritional concerns, your moods, and more. So if you don't have it, check it out. We'll put the link to it in the comments. And if Dr. Chauhan refers to anything in his presentation today, in this conversation, resources, articles, links, medicines, anything like that, we're going to do our best to include that in the comments so that you don't have to open a new, browser window and go seek out that information. We're going to try to give it to you right here in the comments. So let's go. Let's start the show. Go ahead and send in your questions. Dr. Chauhan, you talked about a few things that I'd like to identify. A lot of our patients are new in this journey. And I'd like to kind of lay a foundation a little bit. You talked about your specialty in high-grade neuroendocrine carcinomas. Can we talk a little bit about the different grades of neuroendocrine tumors? Because I think that's a point, we get a lot of questions about that, and I think that's a point where there's confusion there. And I think that I know, even though I'm not an expert, I do know that each case is unique, and the more we know about each person's case, the better chance they have at approaching this. So could we kind of lay down some groundwork about the different grades?
Perfect. I think that's probably the most important question
Great.
in our field. What is the pathology? And unfortunately, this comes across many times where there is a doubt, and that could be alone a reason to encourage a second opinion and going to a higher volume center where the pathologists and the whole teams are accustomed to see these rare cancers and the nuances of it. So by pathology, what do I mean? Neuroendocrine cancer is a big, broad terminology.
Sure.
Where different type of neuroendocrine cancers can be all lumped in together, and these can be all called neuroendocrine neoplasms. But that doesn't tell an oncologist or a surgeon or doctors involved in cancer patient care that how to approach it. So to make things easier and more streamlined, WHO, World Health Organization, they classify the tumors or cancers based on how these cancer cells look under the microscope. And in neuroendocrine neoplasms, we have broadly classified based on the grade and morphology. Grade tells us basically how fast these cancer would grow based on certain biomarkers, and we'll talk about it in a second. And the morphology is how do they look, right? Do they look small, round, blue? Do they look large? Do they have any particular? So morphology and grade are very important. So based on these two factors, we broadly classify neuroendocrine cancers into two big categories. NET, which is neuroendocrine tumor, with T being the key word here, right? Neuroendocrine tumor. And the other side of the spectrum is NEC, neuroendocrine carcinoma. Okay, C being the more, the important word here, neuroendocrine carcinoma. Now, why it's important to early on differentiate these two cancers? Because they are diagnosed in a different way. We do a different set of scans. We monitor them differently, and the treatment's different. So if I have a case and I get these two mixed up, then the whole, down the road treatment would be completely wrong. So it's very important to understand the pathology and the diagnosis. Now, let's talk a little bit about NET first. NET, the neuroendocrine tumor, like Rain mentioned, there is something called as grade. And based on the grade of these neuroendocrine tumors, they are further classified to grade 1, grade 2, and grade 3. These NET, or well-differentiated neuroendocrine tumor, pathologists use a particular dye or stain called Ki67. They create the slide and they stain the cells, and based on how much stain these tumors are taking up, the stain kind of looks brownish. If they're taking too much of it, that means a very high Ki67. If it's taking very little bit about it, it's low Ki67. So what the WHO has done is they have taken up certain numbers to define these different categories. So if your Ki67 under 3, so it's 1 or 2, it is grade 1. If it's between 3 and 20, it's under 20, it'll be grade 2. And anything over 20 of Ki67 would make it a grade 3 neuroendocrine tumor. The other aspect that they have to have a morphology of well-differentiated neuroendocrine tumor to be able to call them NET, okay? Because grade 3 neuroendocrine cancer can also be NEC. By definition, grade 3 is Ki67 more than 20, and they can be well differentiated or poorly differentiated. So in this end of the spectrum, we are only discussing neuroendocrine tumors. So as I mentioned, they can be classified on Ki67, which is a stain, and the pathologist would read out the Ki67. Why it's important for me to know this information? The lower the grade, the less aggressive is the biology, or what we call indolent tumors. So grade 1, grade 2 tumors usually would be slow growing and would have a less aggressive course. What we call natural history of disease progression would be much longer, as compared to grade 3 cancer, which is a little bit more faster growing and more aggressive. So this was NET. Now let's talk a little bit about NEC end of the spectrum of neuroendocrine cancers. NEC is neuroendocrine carcinoma, and by definition, they're all grade 3. There are no grade 1 or grade 2 NECs, okay, unlike our NET categories. So NEC by definition is grade 3, and they're very aggressive. Because they're grade 3, these cells are multiplying rapidly, and the tumors are growing fast. To give you some sort of idea how fast they can grow, there are a couple of different subtypes of NECs. It can be small cell neuroendocrine carcinoma. It could be large cell neuroendocrine carcinoma. And small cell subtype usually occurs in lung, but it can happen anywhere in the body. But the lung by far is the commonest site for small cell lung carcinoma. And some of these tumors can double in 14 days. So that's how fast growing the high grade neuroendocrine carcinoma, especially small cell variety, could be. So very aggressive end of spectrum. That's why it's critical to get a good pathology read so that we understand what are we dealing with here, high grade NEC or NET, and within NET, are we dealing with grade 1, grade 2, or grade 3?
Got it. Thank you very much, ladies and gentlemen, friends of the foundation. When we say luncheon with the experts, we're not kidding around. This man is an expert, so send in your questions. I'm going to go ahead and pivot to some of the questions because we have a lot of them rolling in. We got a lot of people joining us today. The numbers are looking great. Jesse says, when does lymph node involvement become a concern?
Right. So I think that's a great question to segue into the next step. So once we have established the diagnosis based on what the pathologists read it as, the next thing that we as cancer doctor do is stage the disease. Okay, so we have now established the diagnosis. Now we want to stage the disease. And by staging, we mean what's the extent of the cancer spread in the body. Okay, so if I have to simplify things, right, of course, every cancer staged in a different way, and we use what we call TNM staging, where T is the tumor size, N is the lymph node status, and that's how I will kind of loop in the question there, and M is evidence of distant metastases. So we have come up with this staging system for all cancers. Every cancer will have a different definitions for T, N, and M, but just to kind of get the concept through, stage means how far has the cancer spread. So if it's an early stage, stage 1, it's probably limited to the organ where it started. If it's stage 2, stage 3, it has spread loco-regionally. That means cancer has escaped that organ where it started and has now seeded nearby lymph nodes. And if it's stage 4, which is the highest stage of cancer, or also called as metastatic disease, that means it has breached other organs and has seeded other organs, for example, liver, bones, or other organs. So that's just a general broad concept. But coming back to the question, how important is to know whether lymph nodes are involved. It's important to know whether lymph nodes are involved for the staging purposes. If we have no lymph node involvement, then and that kind of reassures us that tumor is probably still limited or very early stage. And if the tumor, especially if it's a low grade or well differentiated neuroendocrine tumor and it's caught really, really early, surgery is the treatment of choice. And if the surgeon can go in and take out all the disease with a good, clean margins, we are shooting for cure there. And that's the reason why we would like to know the lymph node status and evidence of disease elsewhere in the body to get the accurate staging. So knowing if the lymph nodes are involved nearby is important, especially if we are seeing swollen lymph node near a established diagnosed tumor.
Got it. Thank you. Thank you for your question, Jesse. Next question from Anita. And I'm also noticing that the people are sending the thumbs up when it seems like whenever they get a good answer. That's a great visual cue for me. Dr. Chauhan can't see it, but I will let him know if there's a good question.
Thumbs up.
Yeah. A heart emoji, thumbs up, any of that is great to let us know that we're doing our job effectively. That's what we're here for. Next question from Anita, Dr. Chauhan. Have you done any, you had mentioned PRRT when you talked about your, kind of your background on your bio and your specialty. And Anita says, have you done any research on the long-term effects of PRRT?
Right. So great question. And in science in general, we kind of, the good thing about science and medicine is that we don't have to reinvent the wheel. We basically step on other people's work and shoulders and kind of try to carry forward the work.
Mhm.
What I'm trying to get at is PRRT or radioligand therapy is being used for now close to 15, 20 years. It was very, the whole trend started in Europe, where again, I think they are still doing a lot of it, but they were pioneers in early drug development and bringing this drug to the prime time. So we have, from their experience, uh, we have a long-term safety data and long-term, side effect data. From the US standpoint, we got access to PRRT at least on label. That means not on a clinical trial, only after NETTER-1 phase 3 study, which showed positive results and FDA approved it. So our, on-label real-world experience doesn't date back too long. I would say 2018, 2019 onwards. So we don't have that much of follow-up data. But having said that, we have follow-up data for over 10, 15 years from other centers, other heavy volume centers. There is, in Erasmus, etc., which has really helped us understand what are the long-term safety implications of these radiation-based studies. And so far, whatever we have read and understood from other people's work on long-term safety is that we always have to be concerned and always remain alert to potential long-term issues, which can include secondary cancers, etc. But so far, the published data is very reassuring with the rates of bone marrow disorders like myelodysplastic syndrome or leukemias or blood cancers, because it's the bone marrow which is very sensitive to radiation, can develop long-term cancer risks, are very low, less than 5%. One of our friends from Mayo Clinic, Dr. Sunball, he published a really good paper in JAMA Oncology last year, which is a very high impact journal. And he looked at all the PRRT studies with long-term side effects, especially related to the leukemias and bone marrow related issues. And they reported very low levels of long-term myelodysplastic syndrome leukemias, which is very reassuring. This is what we want. In our zeal to improve the tumor status and help patients, we should also not forget that there are potential long-term issues. So far, the field where we are right now is very reassuring to know that at least on-label study, the Lutathera seems to have a good long-term side effect profile. But in the US cohorts, we will see as time matures, we'll get more and more follow-up data. I'm clearly very young to know 15, 20 years data because I started doing PRRT late 2018, early 2019 onwards. But since then, we are treating about 2 to 3 cases every week. And we have a very busy practice. And I treat high-grade cancers as well, a lot of chemotherapy, biologics, targeted therapy. My experience has been very, very positive with peptide receptor radiotherapy based, radionuclide therapy based treatments, very well tolerated in most patients. Usually we don't have major issues.
Got it. Got it. We had a little shout out from Dr. Ramirez, who we've already mentioned today. He says hello from NOLA. Said he's looking forward to learning from Rain and Dr. Chauhan. So I don't know what he's going to learn from me. Maybe a human flag or
There's nothing that Dr. Ramirez can learn from me either. He taught me that
right.
during residency, but
Yeah, that's kind of you, Dr. Ramirez. Also, he makes fun of me for flying push-ups, so maybe I can teach him how to do those
yes, yes.
along with the human flag. Okay, next question. Moving along. Um, question from Lori. She is more of a statement, but we've kind of touched on this. I'm anxious to hear what is coming for the high grade community. Are there any new developments for that community now that we've kind of established who they are, what that is, what that means?
Um, Very apt question. I think we are already behind. I wish, things were a lot better. I'm very happy how rapidly things are advancing in the well-differentiated neuroendocrine community, and that's partly because of increased awareness and all the great things, experts and patient advocates like you guys and the patients have really helped foster that movement and garner that attention. We are lagging behind high grades in that kind of sense. And hopefully next 5 to 10 years, things would change. People would start talking more about high grade cancers, high grade neuroendocrine cancers, so that we can get some attentions, we get some funding, both from industry, from NCI and IH, so that we can do some good research and translate these research into meaningful clinical trials. Now, coming back to the specific questions, is there anything out there which looks exciting? So in high-grade neuroendocrine cancer, usual treatments, because it's such an aggressive cancer, are more chemotherapy-based.
Okay.
And the unfortunate nature of chemotherapy is it works, but there is no durability of response. That means even if it works for a certain amount of time before the cancer cells become smart and develop resistance and find an escape mechanism to evade the chemotherapy. In that case, we end up switching a different type of chemotherapy, which attacks the cancer from a different, different way, in hopes that this would work. However, chemotherapy, prolonged chemotherapies are toxic and does take its toll. So we are trying to find ways to smartly fight cancer, at the same time preserve the quality of life, and it's not too toxic. In that sense, we were hoping that immunotherapy, which is a lot better tolerated in most patients compared to multimodal cytotoxic agents, there was some early data last year from SWOG DART study, which looked very promising. However, it is a small study, very few patients. And then there was some issue with what high grade patients did we enroll? Were they well differentiated grade 3 or the poorly differentiated neuroendocrine carcinomas? And that has really muddied the water. So we are not 100% sure if immunotherapy is going to be that big breakthrough that we are hoping for. I certainly do hope. I've had some anecdotal positive experiences with the immunotherapy in high grade scenarios, and so does some of my colleagues. However, these anecdotes are not rule, and we are waiting for robust data from clinical trials and bigger studies. In that sense, I'm very excited about a clinical trial which is going on right now. We have it open here at Markey Cancer Center. The national PI of that trial is from Wayne State University in Detroit, Dr. Tess Fai's good friend. And the trials, I think, open in multiple sites. It is specifically trying to answer the question whether immunotherapy works in high-grade neuroendocrine cancers. And they are utilizing three drug regimen. One of them is nivolumab Opdivo, other
Hmm.
one's called ipilimumab Yervoy, and the third one's called cabozantinib. So it's taking good from both worlds, immunotherapy, two immunotherapy drugs, and one a pill called cabozantinib, which there is some data to support, preclinical data to support, by adding cabozantinib, we can make certain tumors respond better to immunotherapy. With that hypothesis in mind, this study is open and it's funded by NCI. We are hoping that this study will show us some responses. This is too early, and hopefully in another year or two, when the study completes, we'll know whether immunotherapy has any role in high-grade neuroendocrine cancers. Now, this particular study is only looking at the large cell or poorly differentiated carcinoma subset of neuroendocrine cancers. There is another subset of high-grade neuroendocrine cancer called small cell carcinoma,
Hmm.
and that subset is excluded from this particular study. But we have another study by Dr. Anish Thomas. He's a very smart oncologist at NIH, and his interest is high-grade neuroendocrine cancer, especially the lung cancers, so small cell lung cancer. And he is leading this study where we are using a cytotoxic chemotherapy called topotecan. So topotecan acts against these high-grade neuroendocrine cancers by damaging its DNA. But then why does the cancer survive the insult of the chemo eventually? Is because the DNA repairs itself, and this cancer DNA has this a lot of capability to repair itself. So they are using a second drug called ATR inhibitor, which tends to prevent that DNA repair process. So by giving these two drugs together, you're causing the chemotherapy is causing the tumor DNA to damage tumor DNA, which would cause cell death, the tumor cell death. At the same time, the ATR inhibitor would prevent the DNA repair in the tumor cells to keep the tumor in check after the chemotherapy. And with that hypothesis in mind, this study is being developed and it is enrolling. We have it open here as well at Markey Cancer Center for specifically for small cell subset of these high-grade neuroendocrine cancers. These are just two examples.
Hmm.
What's coming down the pipeline? I'm very interested in oncolytic virus therapy. So we are developing some concepts with oncolytic viruses. These are viruses which don't cause diseases as humans, or they are engineered in a way which don't cause disease in human, but are engineered to attack the cancer cells by various mechanisms. One of them could be that you inject the cancer cell with these viruses, they grow and then they destroy and then move to a next cancer cell. So we are working on that concept. I hope that we can bring it to fruition in the near future. So oncolytic virus therapies are being developed, vaccine therapies, and something besides the immunotherapy that we personally at Markey are trying to invest in high-grade cancer management is radioligand therapy in this space, which is very well established in low-grade NETs, the PRRT, but there is a small subset of high-grade neuroendocrine cancers which can also express some of these targets, for example, somatostatin receptors. Can we give PRRT to these subset of patients? That has to be explored, and there are some trials looking into it currently, and we are also developing some studies here at Markey, trying to leverage or harness that radioligand therapy or PRRT therapy to treat these high-grade neuroendocrine cancers.
Got it. Thank you so much. Dr. Chauhan, we have a couple of questions about lung nets. Are you comfortable talking about lung nets, or how do you feel about that?
No, that's fine.
You good? Okay. Um, okay, so we'll stick with this because there was two or three. So first one is from Kathy. Says, Dr. Chauhan, what treatments are available for lung nets outside of surgery? Is PRT or lanreotide effective for lung nets? Afinitor stabilizes tumors, but is there anything that shrinks them?
Right. So Yeah, just right off the bat, I see neuroendocrine tumor and patients, regardless of the site of the cancers.
Okay.
Various places people manage these cancers differently. So there's a thoracic team, there's a GI team. Here at Markey Cancer Center, we have a dedicated neuroendocrine clinic, so which is site agnostic. So I have patients with ovarian neuroendocrine carcinoma or
Okay.
breast neuroendocrine tumor. As long as it's a neuroendocrine cancer, low grade or high grade, regardless of where it started from, we see them here. Now, coming back to your question, how do we treat lung NATs? Now, um, if you have well-differentiated neuroendocrine tumor, we follow the same treatment principles generally, regardless where the tumor originates from pancreas or midgut, small bowel versus lung. The difference is that because it's a rarer subset of neuroendocrine tumor, what I mean is most commonly neuroendocrine tumors, the well-differentiated neuroendocrine tumor occurs in GI tract. So your small bowel or your
Right.
pancreas. Lung nets being the third most prevalent out of those three. So when we do the studies or when industry does the studies, these lung nats patients are often excluded, which is unfortunate, but to keep the data clean and get a very good scientific data, they are often excluded, which leads to lesser on-label treatment options for lung nats. However, slowly but surely, this is changing. For example, um, you know, for frontline management of metastatic lung net, we will treat them with somatostatin analog, just like we do with the GAP nets. Now we also have Afinitor, which is on label available for lung nets based on the RADIANT-4 study. So FDA did expand it. Previously, it was only on label for your GI or GAP nets. Now we can treat lung nets patients without worrying about insurance not covering because it is on label. However, the problem becomes moving to PRRT. We know that PRRT works, and especially if you have somatostatin receptors. But PRRT was officially studied in NETR1 only in the midgut neuroendocrine tumor population, and based on that, FDA only approved it for your GEP-NET patients. So it's not on label for lung NATs, which is very unfortunate because the insurance now can come back and deny the treatment, which is not appropriate, but it is the reality fact. In reality, it's not often that that happens. We are able to talk to the insurance and do the peer-to-peers and explain them, hey, if there is a lung net patient which is showing somatostatin receptor, that means we have targets for the PRT treatment, then this is a good treatment option, especially if we are running out of standard treatment options. So PRRT for a gallium 68 or net spot positive patient is another treatment option for lung net patients. Besides that, clinical trials, if they are including lung net patients, would be another option.
Are there any coming up that you know about?
Um,
I know there's a site that clinicaltrials.gov that right?
Correct. So the best way to find out, we unfortunately don't have anything active for specifically for LungNet at
Okay.
Market Center. We do have some phase 1 broad clinical trials, which would include any cancer patients and including LungNet. So, and many cancer centers would have these phase 1 trials, but specific neuroendocrine tumor trials looking at just lung nets are very few. I know that Dr. Delpasan in Houston has a PRRT LungNet trial. So if there is a patient who is having issues with standard of care Lutathera approval for their LungNet because of insurance issues, I have found this online on clinicaltrials.gov, and I've referred the patient there because at least they have the protocol there to include LungNet patients. But the trials can open and close, so this is a dynamic process. You know, as soon as the trial met its endpoint, or there are some other issues, they might open and close. So like you mentioned, I would encourage people to look into clinicaltrials.gov. It's a website maintained by US government. It's a federally funded resource. And all the clinical trials are supposed to be registered here. So you can do a quick search, lung nats, and then you can filter the search active trials or actively enrolling, because it'll show you all the studies, the ones which has even close to accrual, and it'll give you all the key information, the key contacts, where all is the trial accessible. Some trials are multi-center studies, so it could be available in a center close to you. You don't have to go all the way to a different state. Some are only limited to a certain site. So it'll give you all the key contacts, numbers to call, and it'll tell you what the study is basically about, what are the primary endpoints, or is the study looking at the tumor control, or is a symptom control study, and what are the kind of drugs. Is it an oral pill? Is it an IV drug? And how many times a month you'd get the IV? So you'll get all that critical information from clinicaltrials.gov.
Awesome. Thank you so much. And thank you for your question. Ladies and gentlemen, friends of the foundation, we got 20 minutes left with today's episode of Luncheon with the Experts with Dr. Chauhan. Dr. Chauhan. Yeah, I know, right? Dr. Chauhan, I believe we announced this last week too. I believe we'll let you know for sure after this, but I believe we might have new record numbers for you, my friend. I told you, everybody, that he was a rock star in the making. I've been watching this the past 2 years, and his star is just soaring. And we've been saying that announcement every week. So our show is soaring too. We're super excited about that. So I know we've got a lot of questions. There are a ton today. Since, like I said, we have record numbers, so we're trying to get to all of them, but we might just have to have Dr. Chauhan back on the show. And just a reminder, we do this every week, so come on back, Doctor.
I can't take it. I think it's all you. And
yeah, right.
Said you are guys on a right trajectory, and thank you so much for doing this.
Of course.
Many patients unfortunately don't have access to net experts, and this really gets them some
absolutely
great ideas and resources and links.
So fortunately, a lot of the questions are kind of around the same sphere today. We had several about lung nets. Thank you for taking some time to address that. We also have several about PRRT. So we're going to spend some time there, if that's okay with you. We've already spent some time there. To that point, really quickly, just know, everybody at home, you can always refer back to this video. It's going to live here on the Facebook page. You can come back to it and check it out later. You can watch it again, watch it 5 times, as many times as you need to. Sarah says, Dr. Chauhan, Sarah says, how long does PRRT work? Right. Simple question, but probably not a simple answer.
Right. Great question, Sarah. And based on the data, and I would say the best data out there, the cleanest data out there would be from the NETTER-1 study, because it was done with intention, prospectively, with an actual good control arm. So we know, and we followed them. We are still following those patients on the study. We know the median PFS, that is how long the cancers or the tumors were stable on the scans. It's very simplified manner, was in the range of 30-35 months. Now, what does that mean? That is median for, this is a trial with so many patients, over 100 patients, so that's median. But there are patients which will breach the median, would be on either side of the medians, right? Median is, if you draw a bell-shaped curve, there's the most of the patients in the median, right? But you have patients on either side of the median, the ones which didn't do as well as the median, and the ones which did really well, twice as good or 3 times as good. So we do have patients who might go several years after the PRRT treatment with complete stable disease. Okay, and very rarely we'll have some patients. Fortunately, these are less than 15% who don't respond at all. They are what we call primary refractory neuroendocrine tumors. That means we gave the treatment, it didn't work at all, and the cancers just started progressing right away. Fortunately, that is a very small number. Okay, most patients will respond, and the question is, how long would it respond? We don't have a good test to say, if you have this you will respond 30 months. If you have this, you will respond 50 months. We don't have that really good one test to give you exact number of months, but I can assure you most patients do well with really good disease stabilization for several years, and some might even do better than the median and kind of go for several more years. Now, even if the cancer does come back, which it eventually can come back, right? Because these treatments are not curative, right? So we can't completely get rid of them. We are just putting them in some sort of stabilization state, making dormancy, but our worry is eventually the cancer would start growing again, shift its gear. Even when it comes back, there is some data coming up that we can consider retreatment with maybe 1 or 2 doses of PRRT, and might be safe to do that. But again, these are case-by-case decision needs to be made in consultation with the oncologist based on how well your kidney, liver function, and other things are. Can you get more treatment or not?
Sure.
But if you responded so well for the first treatment, the case can be made down the road several years later that you can be considered for retreatment, especially if we don't have other good treatment options.
Got it. Linda asks, when there are multiple metastases in the liver and the primaries in the intestines, would PRRT be a good option? Would it be an option?
Um, so PRRT has been approved for metastatic disease regardless of where the metastases are.
Okay.
These are, metastatic progressive GEP-NET patients, at least progressed on one line of treatment. So it doesn't exclude you if you have disease only exclusively in, let's suppose, mesentery or other areas, or you have to have liver mets or something like that. Having said that, based on our experience in treating with PRRT, there are some patients who do better than others. So PRRT symptomatically seems to work really well in liver mets and bone mets, okay, as compared to mesenteric disease. In fact, just a few weeks back, a couple of weeks back, we had a big conference called GI ASCO, gastrointestinal ASCO meeting. Usually happens at San Francisco. This year was virtual.
Mm-hmm.
There was a poster regarding radiological responses with PRRT in the patients with mesenteric or small bowel disease. Uh, the poster came from Moffitt Cancer Center, which are again one of the net centers, and they do a lot of PRRT. And so what they reported, as expected, was that we don't see tumor shrinkage when it comes to the mesenteric nodules or the mesenteric masses. Uh, in general, the tumor shrinkage just doesn't happen even outside mesentery. The response rates in NETTER-1 study was just 17 or 18%. What does that mean? It's important to know. We talk about response rates. The response rate is basic way to say on CT scans, are the tumors shrinking or not?
Mm-hmm.
And we categorize them: partial response, complete response. Complete response means CT scan cannot detect tumor anymore. That rarely happens. That almost never happens. In neuroendocrine tumors, even partial response, tumors shrinking, over 20, 25%, then even that does not happen a lot. I'm 17 to 18%. Most patients, however, remain stable disease. That means at least tumor is not growing. And if we can keep the tumor stable, because these are more indolent cancer, they just don't show us that shrinkage, we are happy with that. The problems comes when they are progressive disease, they start growing. Okay.
Right.
Now, PRRT is better than other drugs, your sandostatin, lanreotide, Afinitor, in terms of tumor shrinkage. These other drugs had response rates in single digits, 5%, 6%, 7%. At least with PRRT, we moved into double digits, 17, 18%, right? Based on the data. However, we are trying to push the limits, right? We are developing new studies, new trials. We have a trial ongoing right now in Marquee, which will soon also open nationally at various other sites. And we have some other PRRT trials coming in the pipeline. With keeping that as one of our goals, can we improve the tumor shrinkage capacity of PRRT? Can we increase the responses 30%, 40%? Shrink these tumors. So we are doing these combination PRRT trials where we're adding a radiation sensitizer, for example, triopine in this case, to the Lutathera, and trying to see if we can get more out of the Lutathera, shrink these tumor more. So science, we are working on that, but tumor shrinkage is always a challenge in neuroendocrine cancers. However, we are very happy as long as we are able to keep the tumor stable. That is sufficient in most cases. There are unique instances where we do have to shrink the tumor because, let's suppose, the tumor is dumping a lot of serotonin, or it's a functional neuroendocrine tumor. In that case, we can use other approaches like embolization or surgical debulking to achieve that. But our systemic treatments are usually what we call cytostatic, keeps the disease stable, often don't shrink the tumors. We are working on it. Hopefully we can share some good data with you guys in a year or two that we are seeing some shrinkage or not, but it's in process.
Awesome. Thank you so much. Moving right along, because I know we have a lot of questions. Dr. Chauhan, we've got a couple questions about this just for clarification. Can you give us an easy explanation of what net theranostics means, what that is?
Right. So theranostics is a concept which some people say that therogeneous is a better term, but it started off as word theranostic. What it means is a technique or principle by which we diagnose and also give therapy using the same principle. And give me a second to kind of explain it even better.
Okay.
So theragnostic is therapy and diagnostic clubbed together. Okay. Now let's take an example of neuroendocrine tumor. Neuroendocrine tumor is really the flag bearer of this whole field, theragnostic. I think prostate is coming up because they have a similar drug, PSMA. Okay. But this is where it kind of caught traction. So imagine a scenario, and not even, in neuroendocrine tumor, the well-differentiated entities, they have on their surface what's called somatostatin receptors, very unique to neuroendocrine tumors. It's one of their properties that they have somatostatin receptors. Now, smart guys in Europe, back in the days, they decided, okay, we have a target, somatostatin receptor. Let's create a missile which just focuses and tracks the somatostatin receptors, right? That is somatostatin analog, right? So you inject somatostatin analog, it'll go circulate in your blood and try to find somatostatin receptor and sit on it, right? Now imagine if you load up this missile with a nuclear sort of material, like a mini nuclear bomb, right? So that's a radiation, that's a radionuclide therapy, right? So we have now leveraged this principle to both diagnose neuroendocrine tumor as well as treat it. So what we have done, we have a somatostatin receptor on neuroendocrine tumor. We have somatostatin analog, which likes somatostatin receptor, and we have tagged that somatostatin analog to a small radionuclide called gallium-68, right? So it is called NetSpot. Everybody probably heard of that. When we inject this gallium-68 dotatate, it goes into circulation and then finds wherever the neuroendocrine tumors are, sits on it, and then emits the radiation, which our scanners pick it up, right? So this is one way to diagnose neuroendocrine tumor, and NetSpot is pretty good in doing that. It's 91% sensitive and specific. Unless your tumor is very small, less than 3 millimeters, or some other cases, it will usually pick it up, right? Now, same concept. So this is diagnostics. We have diagnosed the cancer. How do we convert the same concept into therapeutics? You flip this gallium-68, which is a light radiation moiety, and flip it with lutetium-177, which is a heavy duty, it's much stronger radiation, but rest of the concept is the same. Attach lutetium-177 to the somatostatin analog, inject it into your bloodstream. It'll go wherever the somatostatin receptors are in your tumor, and it will now radiate and destroy the tumor. That's the general concept. So same concept we're using for diagnosis, just flipping the radiation molecule or radionuclide from gallium-68 to lutetium and making this into a therapeutics. So theragnostics, right? So diagnostic and therapeutics in the same concept, right? Awesome. So this whole field is called theranostics, where we have a molecular marker, we target that and use that for diagnosis, and then use the same molecular marker for therapeutics by attaching a different radionuclide. That's in general called theranostics. And my personal bias is I'm director of theranostics and Marquis, so I might be biased, so take it with a grain of salt.
Fair
this
enough.
is an up and coming field. We had an immunotherapy wave in last 5, 10 years. I think theranostics going to come up big time. We will identify new targets, not just neuroendocrine tumors, other solid tumors, and we will find drugs, targeted radioligand therapies to treat these cancers. I think we are just scratching the surface right now.
Awesome. Let's see. Next question. We actually had a couple about this topic as well. Can individuals, this is from Karen, but we had multiple people with similar questions. Can individuals with multiple tumors have tumors with, can those tumors have different grades? Can they have multiple tumors with different grades?
It is possible.
Mm-hmm.
By convention, most of the time, the tumors are, if I have a primary tumor in, let's suppose, pancreas or small bowel, which is grade one,
Mm-hmm.
usually metastatic tumor would also be the grade one, be it in liver, lymph node, or other sites. However, neuroendocrine cancers can be a little tricky, and sometimes we do see what we call heterogeneous disease. That
Mm-hmm.
means the tumor can switch grades, and the metastatic disease can be a little bit more aggressive, so can have grade two. It is a little bit less common, but it does happen.
Okay.
In high volume net centers, we do see this a lot just because we see a lot of neuroendocrine cancers.
Sure.
Out in community, I probably would not expect this to be a norm, but here we always have to worry about this particular scenario. So if I do a gallium 68 scan and I'm seeing very patchy uptake, some tumors are picking up high, or that represents that they are very dense in somatostatin receptors, so
Mm-hmm.
they're probably more well differentiated, probably lower gradish. And some are completely photopenic, that means they're not taking up somatostatin analogs, that they could be de-differentiated, or more high grade. And in those particular scenarios, we often do another scan called FDG PET scans. So there we have to be cognizant of heterogeneous disease, and it's case by case, especially if some tumors are very well controlled, very slow growing, and others are growing fast. That's another scenario we have to think about. Could this be a heterogeneous disease? Are we dealing with two different grades of tumor? And if that happens, we have to uh, gear our treatments towards the higher grade. We always treat the higher, more aggressive biology.
Got it. Next one is just a comment, but it aligns with our purpose here. Jesse says, it's so nice to be able to sit down at home and digest everything. When I'm at the doctor's office, my brain disconnects and I can't remember what I wanted to ask. Thank you so much for providing this fabulous service to us in need. Jesse, thank you for being here. You literally described, one of our main goals and priorities with this show is to give you that one-on-one session when you can digest it at home without being in the doctor's office where things might seem rushed or a lot of new information is coming at you and confusing you. And that's what's great about this video being evergreen and living here on the Facebook page, because you can refer back to it. You can watch it again. You can take notes. You can share it with people. So awesome that you're here. We appreciate it. We have time for, looks like just one more question. Sorry, everybody, that there was a lot today. We had a question about the COVID vaccine. It's very topical. And I think a lot of people have this question. For net patients, should they get it? Is there one that might be better than the other? What are your thoughts?
Well, um, barring very, very, very few specific things which they should talk to their physician about, my blanket statement would be everybody should get COVID vaccine. I personally have gotten it. Most of my colleagues around me, if not all, have got it. I'm waiting for my second shot, which I'm due in about a week time period. This is not a live attenuated virus type of vaccine, which can give you an actual COVID infection. Okay, so I want people to be reassured, even if they are on immunosuppressive drugs, or even if they are on chemotherapy, or if they are on analogs, or whatever type of therapy they can get COVID vaccine, and they should get COVID vaccine. Many of our patients have had COVID, and and it's not fun. I would highly advise, unless you have a specific case that you have severe vaccine allergies or egg allergies or something very nuanced, then you please talk to the doctor. You've had autoimmune disease like GB syndrome after the vaccine, or something very rare. Again, I cannot do all those disclaimers in this small thing. But
Sure.
overall, 99.9% patients should be able to get the vaccine. You should get it as soon as you have access. I've gotten it. I've encouraged my family members back home in India to get it. I think that would be the probably smartest thing to do in 2021.
Got it. And speaking of India, we did have someone join us, at least one person today I saw earlier in the show join us from India live. So that's awesome to see how this reaches people all around the world, especially live. People will be in Australia where it's like 12 hours difference. So that's amazing.
Fantastic, great.
Dr. Chauhan, thank you so much. That's our time for the day today, folks. But as you can tell, he is the truth. Somebody corrected me and said, no, Dr. Chauhan's already a rock star in the community. But today makes it official. Thank you so much for joining us, everybody at home. As always, we hope that this program helped answer some of your questions. I know there was a lot today, which makes me very excited. Like I said, I think it was another record-setting episode. If we didn't get to your question, again, I reiterate, reach out to Carcinoid Cancer Foundation here on the Facebook page or their website at carcinoid.org. Thanks again to our presenting sponsor, Tercera Therapeutics. We could not do this without their support. My name is Rain Bennett. I'm your host. Thank you for watching. Please join us next time on Luncheon with the Experts. Stay healthy,
Thank you.
stay
Thank you,
safe,
guys.
everybody. Bye-bye, Dr. Chauhan. Bye-bye, friends of the foundation.